There are a number of different procedures, the fistulotomy, the lift procedure, advancement flaps, and the anal fistula plug. Let me quickly go through those. Anal fistulotomy for very superficial fistulas is an effective technique, though, as I pointed out, for patients with perianal skin tags, they may have an open wound for a long time, so it has to be customized to the patient. This is for very superficial fistulas. Opening up, it equalizes the pressure from the internal to external aspects, so the fistula eventually heals. This is what a healed fistulotomy site looks like. The lift procedure is a intrasphincteric ligation. So here's the external sphincter, internal sphincter. There's the tract. And we ligate it and tie off and divide the tract intrasphincterically. This is a clinical view of the same thing. Here's the tract being elevated, and it's ligated and divided. The advancement flap is an internal advancement flap bringing the rectal mucosa and a portion of the submucosa, so a pretty thick portion of the wall down to the muscle, dividing that, taking off the fistula tract, closing the fistula opening, and bringing the flap all the way down so that it covers over where the defect was. Here's the defect, here's the flap in place. Fistula plugs don't work. Foreign body, essentially they fail. The reported rates are much better than anybody's local experience. So foreign body in a Crohn's patient is essentially a bad idea. Here are the reported success rates. Fistulotomy is 100%, though you may be left with an open wound, have to be thinking about the continency issues. Lift procedure, 67% in the reported study from 2014. Advancement flaps, 2011 study, 87%. And the plug, this is probably the best number, but again, it's really gone out of fashion. Fecal diversion is the alternative or the default, usually for uncontrolled colitis and proctitis, medically uncontrolled, and for sepsis that can't be controlled, for failed prior repair or prior treatment, and usually we will, assuming we can control sepsis and the disease, try to repair it and see if it can heal before diverting. For untreatable rectal or anal stricture, permanent diversion is really the only option to reduce symptoms. For unreconstructible scarring or fecal incontinence, which may be a consequence of prior treatment. You can see what the outcomes are: 13% complete remission, partial remission, 41%, no change, about 45%. In this study, about 76% of patients eventually got to reversal. However, many of those patients develop recurrent disease. So the diversion protects the part of the rectum for a period of time while they're diverted, but then once it's reconnected, they develop recurrent symptoms.